Good morning. Good morning, everyone, and a very warm welcome to our 10th edition of Empower Hour, which is focused on patient safety curriculum from World Health Organization. And every topic has been addressed by our Annie Patient Safety Fellows of 2021. We are doing this fellowship in collaboration with Patient Safety Movement Foundation USA. And today we have Ms. Shiny Varghese, who is our fellow 2021. May I request all the participants to keep your mic and video off, please, because we are also live on Facebook. So we don't want to have disturbing images on the screen except the speaker. So thank you very much. So keep your video and audio off. Thank you very much for that. And so now coming back to what I was talking about. So we had been discussing all the topics from the patient safety curriculum from World Health Organization. So this time we have Ms.Shiny Varghese, our patient safety fellow from 2021 cohort. And also she is the nursing head from Manipal Hospital, Bangalore. And she is also an office bearer of our association's state chapter of Karnataka. A very warm welcome, Shiny. Can I request you to come on the video, please? Shiny, may I request you to come on the video? Hello? Hello, Shiny, can you hear me?
Yes, ma'am. Hello, ma'am.
Yeah, hello. Can you adjust your camera a little bit? So that is Miss Shiny Varghese for all of you. And now I'm handing over to Shiny to discuss the topic we have in hand, that safety and invasive procedures. And I really hope that today will be a useful day for all of you who have joined us. We already have 56 participants, and thank you so much for being on time. Once again, I'm requesting you, please do not turn your video and audio. Let's not, disturb where everyone else is trying to concentrate and learn. Thank you so much, everyone. I would request you to adjust your camera again a little bit.
Ma'am, there is some problem here.
Yes.
Unable to share it again.
There, you will share because every time you have to share.
Yeah, yes, but here I'm not seeing this.
On the screen, you will see share.
Correct, ma'am. Would you like to share it, ma'am, otherwise?
What happened? You just tried it, no? Just now you have tried it. What happened?
Yes, but it's not happening here again. Don't know what happened, what went wrong.
You have your IT person to help you?
You can hear me? I mean, you can see the screen, ma'am?
I cannot see the screen.
Okay, I think then.
You have to, when you select share screen,
yes,
on that you will see screen. Click on the screen and then go to your PPT.
That I am unable to see some reason. I don't know why.
No worries. Let me just share so that we don't waste time.
Yes.
Yes. You're able to see the screen now, right?
Yes, I can. Yes, I can. Yeah.
Start and just tell me when to change the slide. I will be right here changing the slide. And
right, ma'am. Yeah. All right. A very good morning to all of you. And so nice to hear you. I mean, see all of you over here. Welcome to ANI Patient Safety Fellowship Program in collaboration with Patient Safety Movement Foundation. ANI, Association of Nurse Executive India, is committed to zero harm. We may move this slide, please, ma'am. Today, we are on the 10th topic where we talk about patient safety and invasive procedure. It is based on WHO patient safety curriculum. Patient safety during invasive procedure must be understood to ascertain the main causes of adverse events in surgical and invasive procedural care and how the use of guidelines, verification processes, and teamwork can facilitate the correct patient receiving correct treatment at the appropriate time and place. Okay, the objective of today's session is to understand the main causes of adverse events in surgical and invasive procedures, and understand how the use of guidelines, verification processes, and teamwork ensures patient safety, and also discuss techniques to reduce risks and errors. Okay, so what do you see in this picture? Can you identify something here? Yes, absolutely. You can see a left behind forceps inside the pelvic cavity. It can happen anywhere. It can happen anywhere.
You said this video needs to be played?
If we can, ma'am, yes.
Yeah.
A major alert from doctors at one of America's leading medical schools. A new report from Johns Hopkins says more than 4,000 times a year, surgeons are making mistakes in the operating room that should never happen and can be stopped now. ABC's chief medical editor, Dr. Richard Besser, with advice for everyone tonight.
A surgical clamp left inside an abdomen, a scissor blade left near a pelvis, even this one, an 18-inch retractor left behind, and surgical mistakes like the one that happened to Lonnie Sowell. They operated on the wrong knee.
I was helpless.
It happens a lot more than you might think.
What we found is that about 40 times per week in the U.S., patients have a sponge or a towel left. 20 times a week, we operate on the wrong side of the body or the wrong part of the body, and 20 times we do the wrong operation.
Dr. Jeffrey Port of New York Presbyterian Hospital showed me what's supposed to happen before surgery even starts.
Make a mark with our initials on the side of the surgery.
The surgeon initials the correct limb. Once inside the OR, everything stops, and they hold up a checklist.
What is the procedure? Does it match the consent?
Nurses should count the instruments and gauze sponges before and after surgery. And some hospitals use a new technology that Dr. Port pioneered, a tiny tracking chip attached to each piece of gauze.
Are surgeons taking this seriously?
Very seriously.
And Rich Besser is here now. So you walk into the hospital, what's the first thing you ask? What's the first thing you do?
Well, you want to make sure that your hospital is using this checklist, using this system. Surgeons call these type of errors never events because they are all totally preventable. And you want to make sure that your doctor is following those rules.
But I was asking you, what about taking your own magic marker, and whether it's you or whether it's someone you're advocating for, go ahead and mark it yourself.
Yeah, I mean, do that yourself. They should be doing that too. And you want to make sure before you're wheeled into that operating room that they know what they're doing and what part of their body they're doing it on.
And if you haven't seen a mark being made,
don't go into that operating room.
take action.
Exactly.
Yeah. Yes. You have seen that in this video, you would have seen how many times things are left behind the abdomen, the pelvic cavity, right? So this all could be prevented. Do you think it can be prevented? Yes, certainly. Yes, we can prevent this. So the statistics may surprise you, right? Ma'am, if you would Please move on to
sitting and working. No?
yes. 230 million major surgeries happens worldwide a year. That's quite a lot. And out of which, ma'am, you'll have to keep pressing. Sorry. 0.4 to 8% die as a consequence of surgical procedures. And 16%, 3 to 16% experiences serious complication out of the surgeries. And 10 lakh death happened due to the surgery. And almost 60 lakh patient suffers major incapabilities. That is the next press, ma'am, in the slide. Yes. So 60 lakh disabilities happens. This is quite a lot. People, it is quite a lot. So many people are being struggled or suffered or, facing the consequences after they undergo a surgery, right? This is quite a lot and we must do everything to prevent them. Do you think can we prevent them? Of course, yes. Let us go to the next slide to see how we can make differences. Let us just go through this case scenario to understand how things could happen. Brian injured his left knee while exercising and was referred by his local doctor to an orthopedic surgeon. Orthopedic surgeon obtained consent to perform an examination of the left knee under anesthesia as a daycare procedure. 2 registered nurses confirmed the consent form for an elective examination on his left knee. The surgeon talked to Brian but did not confirm which knee was to be operated on. Brian was anesthetized. The anesthetic nurse saw the tourniquet draped over his left leg. When the scrub nurse saw the orthopedic surgeon preparing his right leg, she told him that she thought the other leg was the intended site. The doctor disagreed, however, and the surgery was performed on the incorrect surgical site or the other knee. So what happened? What was the major errors in this scenario? What are the major errors in this scenario? The surgeon did not confirm the patient's site while the patient was awake. And the nurses was not brave enough to talk to the doctor to stop it, right? And also, are the responsibilities of the surgeon and the nurses were appropriately carried out here? No, not at all. Was the discussion to be done prior to the patient preparation or before that? Certainly it is before the preparation, right? It has to be done. So many steps are there to prevent an inadvertent thing happening to the patient or a harm causing to the patient. So many times you would have heard this phrase that the nurses are one step to prevent harm happening to our patients. Okay, shall we move ahead? So let's now discuss the causes of adverse events. Adverse events, yes, they are poor infection control, they are inadequate patient management, they are inadequate communication among the healthcare providers. What are the poor infection control procedures? What are the what do you mean by poor infection control? Each one of us have a responsibility to adhere to the infection control protocol. Infection control is everybody's business. I hope you remember last week we have celebrated the International Infection Prevention Week. We spoke a lot of things about the prevention of infection there, right? Yes, absolutely. Yeah, one of the major thing which came across was that the adherence to standard precautions, right? What do you mean by the adherence to standard precaution? What are these? Yes. What are these adherence to standard precaution? What are these precautions are? First and foremost, it is the hand hygiene. Yes, you're correct. It is the hand hygiene. Hand hygiene does a lot of wonders. It is the simplest, cheapest, easiest, economic way to prevent infection. Hand hygiene, right? We need to always adhere to the hand hygiene. When do you wash hands? Right? That is very important. All the time before you do you remember the 5 moments of hand hygiene? Yes, guys? Can we just go back a little bit on the hand hygiene when we wash? There are 2 before and 3 after, right? Before any procedure, before any invasive procedure, before doing any procedure, you wash hands. And after touching patient, after being exposed to the patient surrounding, after being exposed to the blood and body fluids. Yes, we need to follow that. Here now we are majorly, predominantly discussing about the invasive procedures. Yes, there also hand hygiene has a very important, major role. And then in order to prevent the infection for the invasive procedures, we need to always focus on the surgical site care bundles. There are care bundles initiated. Care bundle is a wonderful idea where many part of the care is bundled together and we address to prevent the infection or to ensure the safety of the surgical procedure. That when the infection control, surgical site care bundle is followed, there are research, there are studies shows that predominantly much infections have been reduced. So now what are these care bundles? It is administration of appropriate antibiotic at the appropriate timing, adherence to proper hand hygiene practices, again it has come, adherence to pre-operative showers, skin preparation, that is instead of shaving, the clipping is the preferred method, and also maintaining the normal body temperature and also ensuring the glucose control. So the glucose control always need to be maintained, that ensure that the sugars levels are below 200 mg per dl. Right? I hope you are now familiarized with the infection control part to prevent the adverse event in the invasive procedures. Now going to the other cause of adverse event, that is inadequate patient management, right? What are they? Adverse events like sepsis, cardiovascular events, respiratory complication, thromboembolic events happens due to many indirect factors, right? Or pre-existing conditions. Poor leadership, poor teamwork, work culture, lack of evidence-based practices also causes a lot of, is one of the patient management lack, right? And also, guys, at individual level, lack of proactiveness to prevent accidental injuries, delays, failure to act upon the results, or failure to seek help. So when you talk about these things, right? So the nurse identified that the patient's hemoglobin is low, right? She's empowered to stop the surgery, right? What happens when a patient's hemoglobin is very low and the surgery is being performed, or the platelet count is below normal? You can talk and you can put an alert and stop the surgery, or you can even see that the patient has not stopped his blood thinners prior to the surgery, or the previous day also, the patient has, come for the surgery in the early hours, the same day the surgery need to be performed, the patient has taken the antiplatelet, anticoagulant, and then if you understand that, of course, you can stop the surgery, right? And also, if the patient has not followed the NPO status, of course, you need to alert, right? Every time we are at the bedside, we do spend a lot of time with the patient. We have the right, we are empowered to prevent the harm happening to the patients. So we need to always see that all preventable cause must be eliminated. All preventable cause must be eliminated, right? And that include the patient, the check on, that include the patient in the patient care, right? So when you include patient as a part of the care, things would have wonderful results, right? How do we include the patient in the care? To check and understand whether the patient understood the instructions, right? So there is a lot of language barrier happens. Due to the language barrier, the patient may not understand what was instructed, right? So what we need to do that, we need to ensure that the patient understand the instruction. So if an NPO order is given, when an NPO order is given, nil per oral instruction when you give, you need to ensure that the patient understands. So how do you ensure it? We can ask the patient to tell us what the patient understands, right? When language barrier happens, so see that a translator is included in the care. Okay, so now moving on to the inadequate communication among the healthcare providers, we need to ensure that the communication happens at every step where the patient is being transferred. The proper hands-off has to be done. All vital information about the patient must be handed over, right? Examples of communication failures at different occasions includes the antibiotic missing, the reservation of the ICU bed, or the arranging of the blood missing, and even the positioning, right? All that can happen when the communication doesn't happen properly. So what can we do? How do we address these causes? How do we address these causes? How can we address the poor infection control practices? By always following the infection control processes. Ma'am, if you may please press the next, yes. Implementation of better infection control practices is the answer for the infection control. Yes. And also to involve, us over operation room and the environment involved, intensely complex activities and professional must always include the patients when they are conscious. Okay, how can we improve this communication factor? To have the communication line open, right? When you have the proper communication open, communication channels and open, and ensures the proper handovers are done, the wrong patient having surgery or the wrong site it is being operated or wrong surgery patient undergoing, all can be prevented when we have the communication channels also is be thoroughly operated or practiced. Now let us go to the types of communication failures which can happen. There are predominantly 4 in number, which is occasion. It is due to the content and audience and purpose. So what is this occasions, right? This is like problems in the situation or the context of the communication even is identified after it has occurred, right? When halfway through a surgery, the anesthetist asking the surgeon whether have you followed the antibiotic prophylactic, right? It seldom serves the purpose. It has to be done much before, within 60 minutes of the surgery. the antibiotic needs to be given. 30 to 60 minutes is the criteria. And going to the content, insufficiency or inaccuracy apparent in the information being transferred. What is this? Right, before reserving the ICU bed, the two people involved in the case or in the care is telling, okay, anyway, our ICU is always full. There is not much, no much point in reserving a bed, right? We cannot assume things. What happens if the patient is critically ill? Patient requires an additional an ICU bed, and if you have not booked a bed, right? I know ICU may be full, but if this request is given, they could do so many things can be done, right? Most shiftable or the stable patients can be shifted out of ICU so that an ICU bed can be reserved, right? So never take things lightly, never take for granted, right? So now going to the audience, so there is a gap in the composition of the group engaged in the communication, right? So before positioning the patients, the nurse and the anesthetist decide the position, which position the patient need to be kept. Can we really do that? The surgeon is the one to decide which is the exact position required for the surgery, to be performed. Yes. So now the purpose, we're moving on to the purpose in this failure. Communication events in which purpose is unclear or not achieved or inappropriately communicated, right? So a nurse is asking, two nurses are asking whether there is a tray required with ice box to get the liver transplant, the resected liver to be placed. And both were clueless and they did not confirm with the surgeon, confirm with somebody who is senior, right? So what we need to understand from this is that, guys, never take things happen to chances. We need to always ensure that things have to be followed in the right way. When in doubt, please ask. Clarify your doubts. Okay. Now, there are steps actually, there are processes actually there in order to improve the surgical care. So we are moving on to that. There are guidelines. They are guidelines, protocols, and checklists. What are the guidelines? Guidelines talks about the things majorly to be done, how the procedure is being can be done without error. That talks about the guideline talks about gives a overview of the things which is followed. And what about the protocols? Protocols are the steps which to be followed in order to ensure that these guidelines are followed. And what about the checklist? Checklist tells us, checklist ensures that every time whether these steps, which is written in the protocol, is being followed. So when we speaks about the checklist, the checklist has been actually proposed by Dr. Atul Gawande. He has been, motivated, or he has observed in the airline industry, no planes fall off the sky, right? We don't see the planes fall off the sky every other day. No, we don't, right? Why? Because airline industry is very careful, very serious about the checklists they perform. They do 100 checklists every time before the surgery, before the plane takes off, right? And that is why, right? The planes, it is so safe actually to travel in the plane because they have the protocols, guidelines, protocol checklists in place. The same way, even a surgical procedure is supposed to be so safe, right? So now WHO has proposed the checklist, surgical safety checklist. So when we follow this surgical safety checklist, it saves life, right? There was a campaign which says about safe surgery, safe life. There are 10 objectives. There are essential 10 objectives in this. They are 10 in number. We can go through it one by one. It is the team will operate on the correct patients at the correct site. How can you do that? By doing a site marking. The objective number 2 is that the team will use methods known to prevent harm from anesthetic administration while protecting the patient from pain, right? The correct dose of anesthesia will be administered. That is why we do the pre-anesthetic checks, right? So that they will determine how much anesthesia need to be done, which need to be selected, and things like that. And the objective number 3 is that team will recognize and effectively prepare for life-threatening loss of airway or respiratory function. And the team will recognize they effectively prepare for risk of high blood loss, right? And then the team will have to avoid inducing an allergic or adverse drug reaction known to be significant risk to the patient. That's what every time we will ask, are you known to any allergic drug? Are you known to have any allergy, right? And then the team will consistently use methods known to minimize risk of surgical site infection. We've spoken in length about it. And then the team will prevent inadvertent retention of sponges and instrument in surgical wounds. There are steps also to be followed in that we will discuss little later. The latest slides discuss about them. And then also effectively communicate and exchange critical patient information for safe conduct of the operations. And objective number 10 is hospital and public health systems will establish routine surveillance of surgical capacity and volume and results, right? They will optimize the use of the systems, health systems. Okay, so these are the 10 surgical points we have, safety objectives we are discussed. Now we will go to them one by one, right? So this has to be done in 3 parts. Surgical safety checklist has to be done in 3 parts. It is before the induction of anesthesia, before the skin being incised, and before the patient leaves the operating room. Before the induction of anesthesia, the nurse and the anesthetist do this. It is also called as time in, right? What all do they check in time in? They will talk about, they will identify the patient, the site and the surgery and the consent. They will also check whether the site is marked. They will also check the anesthesia machine and the medication check is complete, whether they are prepared, whether the pulse oximeter on the patient is functioning. Does the patient have any allergy or any difficult airway or aspiration risk is noted, or there is any risk of blood loss, right, is identified. That is called time in. That is done before the induction of anesthesia. Why do we do it before the induction? Because once the patient is knocked off, right, patient is unconscious, you can't clarify anything with the patient, right? This is done in order to prevent the wrong site, wrong surgery, wrong patient. This is called time in, right? The next is before the patient is being incised, right? The patient being operated, the incision is made. This is done with the nurse, anesthetist, and the surgeon, right? Again, the team members will confirm. They will introduce themselves, right? Because teamwork is very, very, very important in order to have a successful surgery outcome. The teamwork, all the team, which is members included in the surgery, it is the surgeon, the anesthetist, the nurse, and other support people, right? So they have to introduce themselves, and they again confirm the patient and the surgery site. Then again, at this time, they will ask for the prophylactic antibiotic. Then whether they have anticipate any critical events, right? also, and also the anesthetist will ask for the any patient specific concern. The nursing team has to be included and to confirm in any threat in the sterility factor here. And also there is any equipment issues at this position, at this stage. And also essential imaging displays also need to be identified at this time. So it is a teamwork, guys. So everyone in this operation has to have their role played, right? You don't need to be intimidated with anyone. Maybe the surgeon is very, experienced, or the anesthetist is very old, right? And you may be little, junior, 1 year or 2 year in the system, but you don't need to be intimidated by anyone. You need to do what you're supposed to be done, right? Okay. Moving on to the sign out. Now the surgery is done. Everything is over. Now it is the sign out time. When it is done, it is who are included in it. It is the nurse, the anesthetist, and the surgeon again. The nurse verbally confirms again the name of the procedure and the completion of the instrument, the sponge, and the needle counts. Right? It is very, very critical. If you do not get the count of your equipments, your instrument, your sponges, and your needle counts, you can stop the surgeon from being, closing the incision, right? Unless you check and understand it is thoroughly, correctly it is done, please, don't proceed, right? Right, there is everything available. The patient is available. You can actually check on the count. You can have an X-ray, CM, or an X-ray done in order to identify it if it is not there. So it is very, very critical that you get the counts correct before you closing, right? And then the specimen also needs to be labeled properly. The readout the specimen labels allowed, including the patient name. These specimens, surgical wound specimens it is very rare, right? It is very precious. You cannot miss it. You cannot label it also incorrectly, right? I remember a story at this time, actually. One of the surgeons, one of the very VIP patient, it was operated, and the skin had to be sent for biopsy. The staff did not confirm in which medium the skin to be sent. The staff thought, okay, it may be in formalin, but again, did not confirm it. And it has to be actually preserved in normal saline. Instead of that, the skin was kept in the formalin. What happens when the specimen is kept in formalin? You will not be able to conduct the examination, the study properly, right? So things like this can happen. The specimen can be missed. Specimen can be mislabeled because in a high volume area, it is very, very easy to get things missed. So it is our responsibility, guys, that it is all correctly identified, labeled, and handed over to the right people in order to have the procedures, the further steps to be followed. Right? And also at the end of the surgery, we need to ask where there is anything, any deviation did you find? Any, difficulty did you face at this time, right? So the WHO safety checklist ensures the surgery, it saves the life. So please adhere to this all the time. Please adhere to this all the time. So now there is a video of how this can be done. Let us watch this.
Hello, I'm Anna, one of the nurses looking after you when you're in theatre today. How are you?
I'm fine, love.
Okay. Could you just tell me your name and date of birth, please?
Joanna Davidson.
Okay.
12637.
Okay, and your hospital number? is correct. What operation are you having done today? Gallstones. Okay, so that's the consent form. I just need to check that you've signed it.
Yep.
And that's your signature.
That's my signature, yeah.
And you're happy with everything?
Yes.
Okay, that's fine. And the surgical sign is not marked because it's not applicable with this one. Are you happy with machines inside and here?
Yes, machines are checked inside and
The drugs?
all the drugs ready.
Okay, are you allergic to anything?
No.
Okay, and difficult airway aspiration risk?
Not anticipated, no.
Okay, any blood loss expected?
Minimal.
Okay, so we're just going to go ahead now.
Thank you.
Ready for timeout?
Okay.
Can everyone introduce themselves by name and role?
Mark Kenny, consultant anaesthetist.
Sampal Shana, anaesthetic registrar. Paul Ziprin, consultant surgeon. George Peach, surgical SHO.
Angela Zupan, circulating nurse.
Natalie Medes, scrub nurse.
Andre Chow, surgical registrar.
Anna, anaesthetic nurse.
Okay, what's the patient's name, procedure and site?
Janina Davison for a laparoscopic cholecystectomy. Her name tag's already been checked.
Okay, any expected blood loss?
Minimal.
Specific requirements?
Laparoscopic cholecystectomy, which has been checked already.
Okay, the critical steps?
Possibility for conversion to open surgery.
Any specific concerns? Anesthetics?
None.
ASA?
2.
Monitoring equipment?
All present.
Okay, is it sterility checked?
Yep.
And any equipment issues?
I've got the standard laparoscopic equipment. Would you be requiring anything extra?
Well, we have the open set on standby.
Antibiotics?
1.2 grams of augmentins in the patient.
And warming?
Bear hugger.
Hair removal?
Not required.
Glycemic control?
Not indicated.
And DVT prophylaxis?
TED stockings as standard.
Imaging displayed?
Not required. You ready for sign out?
Okay. What's the name of the procedure?
Laparoscopic cholecystectomy.
Are the counts correct?
Counts correct.
Okay. In the specimen, it's labelled Janina Davidson gallbladder.
Yes, that's great.
And any equipment problems?
No.
No.
And key concerns for recovery?
No special concerns.
Thanks.
Yes. So, right.
ಇದು ಗ್ಲಾಸಸ್ ಇಲ್ಲ ಕಳಿಸ್ಲಾ ಗೀತಕ್ಕನ ಮೇಲೆ
And what are the actions we need to take in order to follow, in order to ensure that our patient is safe? Follow the verification process to eliminate wrong patient, wrong site, and wrong procedural incidents, right? So we have discussed this in the surgical safety checklist. We have seen it at length, right? We spoke about it in the video also. It was so evident, and it was seen that how a surgical safety checklist need to be followed. And action number 2 is that practice operation room techniques that reduce risk and errors, right? These timeouts, pauses, briefings and debriefings and stating concerns. We need to see that we follow this. And another one is that the third action what we need to take is that infection prevention practice are adhered to all the time, right? It is actually not very, difficult if you follow these steps, right? It is very easy actually if you follow the steps, right? So follow these processes at all the time. Don't resort to follow the shortcuts, right? Don't resort to follow the shortcuts. Always follow the processes and procedures at all time. Right. Okay.
Do you play this video?
I think we have done it, ma'am. It was covered in it. The same thing again. Okay, so in summary,
implementing the
summary, guys, we have spoken about the guidelines, protocol, and checklist, right? We may have everything, but if you do not trust it and if you do not follow it, it's of no use, right? So if you do not have a protocol or a guidelines about this, please ask your leaders, right? I would like to know about our protocols, where it is being kept, right? So sometimes it may be available in the paper form, or sometimes it may be on the online format, but every hospital must have this, right? And you must see that you follow the protocols, you read it, you understand it, and you follow it. So what we suggest in our hospital is that at the time of our induction itself, familiarize people with these guidelines, especially the team members who is posted for the, assigned for the operation theater as the designated work area. We go through these steps, surgical safety checklist and these procedures at very length, and ensures that they adhere to it all the time, right? So a guideline is only useful if the people use it and trust it and understand why it is used, how it is used and why it is used, and how we can prevent the mishaps or inadvertent things happening to the patients. And protocols can prevent the wrong patient from receiving the wrong treatment, as well as facilitate better communication among team members, and also, which also includes the patient as a team member of the patient care, right? So that is about it, right? So things can be prevented, and if we follow and if we focus on it, things can be prevented, that when we are adhering to the guidelines, protocols, and checklists, right? Seeing that it is being done, and it is done, it is authentic, meaning and purpose, right? So thank you for participating. I wish that all the patient who comes under care may have a safe surgery, and let their lives be saved. Let the lives be preserved. Thank you, everyone, for your patient listening. Thank you.
Thank you. Thank you, Shiny, for that simple to understand focus on the surgical safety. May I request you to stay on the video, please? Don't run away. Thank you. See, in my experience, I mean, I'm almost 40 years in the hospital. Most of the hospitals will have all the protocols and policies and checklists in place. One of the most dangerous thing that I have experienced is that checklists become tick list. That is something that we should always keep in mind, because checklists can become very dangerous, because when we audit, we tend to audit if the checklist is complete or not. Yes. And we don't actually see the process. So many years ago, when WHO patient safety came into force, we introduced that in the system. And then we went about auditing whether it is being practiced. That is the time we saw the gap, because in the file, we found everything perfect. All the checklists were, ticked and signed and everything. But when we actually watched the process, we saw many gaps. So I usually feel that, not every patient will be harmed when something you are not doing properly. But one day, somebody will be harmed, and that somebody is not a statistics. So I always used to argue, no hospital can say that after 10 years, we operated on a wrong patient. Patient is somebody's someone, and the error is, 100%, right? So I totally agree with you that there is no shortcut for safe practices. One has to follow the safe practices every time and each time. You can't say, I have done this, 1,000 times, so I am very confident, it will go well. I mean, that is the one last bit I would like to, share with everyone. Sitting here, you can see that there are a lot of students here. A big shout out to all of you that always learn the best practice and just follow the best. Don't follow anyone who is not showing you the right. It's not worth it. You don't want to be a party to a patient harm for your entire life. You're not going to forgive yourself for that one moment of overlook or one moment of carelessness just saying, oh, it's not going to happen. So this is very, very important. One shout out to all the nurses and especially to the students, because you are the future of, nurses and patient safety. Yes, as leaders, we carry the responsibility of ensuring that right thing is done. So thanks, Elizabeth. She's typing in that, sign in is before induction, and just before incision, it is timeout, and then it is sign out, So the words could be slightly different. In some hospitals, could be time in, time out, and sign out, or it is sign in, time out, and, sign out. But in all this, when Shiny was, explaining, and we saw the video also, you saw one common factor apart from the patient. Patient is a common factor in all the scenarios. The other common factor was the nurse. So how much of responsibility all of us are carrying? Are we respecting the responsibility that is entrusted on us? These are questions that we need to ask while we work with our patients. Is it really worth taking shortcut? I also would like to just enlighten on one more word. Many of us talk about it all the time in hospital. That is called integrity. Integrity has a very simple meaning: doing the right things when nobody is watching. I think that is the most important value for a nurse or any healthcare professionals for that matter. What are we doing when we are not being watched, when we are with the patient, when nobody is auditing us whether we are following the checklist correctly or not? So I was thinking about all these things when Shiny was discussing through all the, surgical safety checklist, and Dr. Atul Gawande has a book called Checklist Manifesto. If anyone is interested, you should read that book. It is very important. Checklists have saved a lot of maternal and infant deaths in India, because all the ASHA workers and all those ANMs out in the community, they're using checklist. Because they use the checklist very diligently, we were able to reduce the complications around maternal health, right? So it is possible to be achieved. And nurses, we are the patient safety champions. Or as Dr. Michael Ramsey, the CEO of Patient Safety Movement Foundation, when we had the meeting with him, all the fellows, he used one word: patient safety soldiers. And I really liked it, because we are soldiers. In a war, soldiers are the ones who fight and keep us all safe. So here, nurses are the soldiers who are going to fight and keep the patient safe. Thank you everyone for being here. And before you leave, I just want to give you a few information on Annie. And just before that, if anyone has any question for Ms. Shiny, you may unmute and ask. In case anybody has any questions or any comments are coming here. All are agreeing that, it is important.
Yes, ma'am.
So someone mentioned here, the count of instruments, gauze, mops, needles should be confirmed during timeout before incision. That is before closure of the incision. I totally agree. All the surgical count, instruments, gauze, everything needs to be done before the closure of the incision. The WHO surgical safety checklist is showing that in the sign out is only because to confirm that everything has been done. So that is part of the surgery that, before you close, you have to ensure all your counts are right. Yes. If anyone has got a question, Kavita or someone, do you have a question? Put your hand.
No, ma'am.
Oh, okay. All right. So just give me a moment. First, let me just share the presentation that I have got to talk about. Are you all able to see the screen? Can you see my?
Yes, ma'am. We can see that.
Okay, great. Let me put it on the slideshow. So as you all know that, Association of Nurse Executives India, we are committed to patient safety and we are committed to nurses and nursing in India. we are working together to ensure that tomorrow is better for nurses and nursing in India. When patient care becomes better, patient safety becomes better, the nursing and nurses will come into focus. For that, we need to be strong. We need to be courageous, and then we should speak up when things are not safe. So that's how we have started the Annie Patient Safety Fellowship Program last year. So this year you have seen all the fellows, presenting this. This 2022 cohort also has got, very senior people undergoing the fellowship program. And hopefully in 2023, we will have the next cohort. And this time they are also doing quality improvement projects, using guidelines, Safety Movement Foundation. So a big announcement that this year, we are going to have the elections for the national office bearers. That means the country's president, vice president, secretary, and treasurer. So this is, obviously, this will be conducted among the members. So if you want to know more about Annie and the election process, the information is available. And the annual Annie's General Body meeting is going to be held on 10th December 2022. This is for people who are members in their calendar, so you can attend this meeting. And obviously, we are inviting any nurse who would like to join us and make our collective voice strong. I mean, that is the strength of, working together for a good cause. The cause can be for patients, for nurses, but we need to come together without any discrimination or without any other motive except that, you want to contribute towards nurses. So the last topic will be dealt with Mr. Vinod Kumar in November, on 26th November. That will be on improving patient safety. And in December, there is going to be a mega quiz on all the topics that had been covered in this year. So please watch out for the, information. And if any one of you have not yet watched the previous recordings, please go to Annie's YouTube channel. You will find all the recordings there. So we will be having a quiz competition. The format and what will be the prizes, all that will be announced by Annie in due course of time. So I really hope that all of you will start preparing from now itself, because all the previous sessions recordings are available on the YouTube channel of our association. So yes, so that is it. That's what we had. Much everyone for being here, and I'm going to stop sharing on the Facebook, and all the people on the Facebook, thank you for watching us, and keep visiting us whenever we have such learning sessions. Thank you. And thank you so much, Shiny, for being here and taking us through this particular topic, and very, very critical and very important topic. Thank you so much, Shiny.
Thank you, ma'am. Thank you for the opportunity. Thank you very much.